I think what this situation does is it provides us an opportunity to adopt telehealth technology and increase telemedicine services all across the board.
Thank you for listening to Value-Based Care Insights, a podcast by Lumina Health Partners. I'm your host, Shaillee Chopra. The series is for healthcare leaders and organizations navigating the journey to value-based care and the ever-changing landscape of our healthcare industry. Our goal in this series is to bring to you disruptive success strategies for healthcare organizations, leveraging our experience and having worked with some of industry's top experts and thought leaders. And before I get into today's episode, I'd like to invite you to leave us a review on Apple Podcasts and let us know what you think about this episode and other questions that might be top of your mind. With that, I'd like to welcome my co-host, Dan Marino, Managing Partner at Lumina Health Partners and an industry thought leader for value-based care. Dan, welcome.
Thanks, Shaillee. How are you doing today?
I'm doing well, Dan. Dan, in our last podcast episode, we talked about how to set up for telehealth visits. What setup is needed in the office or at home to optimize the patient and provider experience when conducting care through telehealth technology, and what other things to be mindful of as you redesign the workflow, be it documentation, be it how to leverage the EMR templates when documenting the telehealth visit. And Dr. George Mazel, in his webinar, had some great pointers for our audience. By the way, I also want to point out to our listeners, if you want to go back and listen to the prior episode on telehealth with Dr. George Mazel, it's available on our podcast platforms. So Dan, let's talk about today the other side of completing the telehealth visit. Once you've conducted the visit with the patient, how to document it, bill for it, and apply the appropriate codes so you get reimbursed for it.
Well, as Dr. Mazel said on the previous podcast, changing the workflow to take advantage of the telemedicine, telehealth visit is really going to be important. The virtual visit is different than the in-person visit. And as he mentioned, you really need to think about how or what needs to occur when you're setting up the visit, the scheduling, as you're conducting the visit, and then what happens post-visit. So from a clinical perspective, that thinking through that clinical workflow is really going to be important. But as you mentioned, there's a whole other side to this, right? So it's understanding how some of the administrative components and some of the billing components really need to support the telehealth visit to ensure that you're closing the loop with the patient, but also ensuring that you're billing and collecting appropriately. The last thing you want to do is overburden the patient with a telehealth or a telemedicine visit.
Absolutely. And I'm so excited that joining us today for a podcast is our managing partner, Lucy Zielinski, who has worked with clients on setting up the telehealth visits and really brings forth a lot of practical tips and insights on how to appropriately bill, code, and get reimbursed for these visits. Lucy, welcome.
Thank you, Shaillee and Dan. Glad to be here.
Well, Lucy, when you start to think about the telehealth visits and all those, the clinical workflow, as we mentioned, and Dr. Mazel highlighted this a lot, the administrative structure really does have to change. And maybe we could start at the top. There's a lot of nomenclature that's out there in terms of an e-visit, telehealth, telemedicine, all of those areas, virtual visit, and so forth. Can you break down a little bit or provide a little clarity on all of those areas if you can?
Sure, Dan. You're absolutely right. There has been a lot of words used, many of those you mentioned and others. And I think the way I think of it, and there's experts in the field who have defined it as such as well, whereas most of the work that physicians are doing relates to obviously clinical services. And performing remote clinical services can be termed as telemedicine. So the work that physicians are doing is telemedicine. And that telehealth term is a broader term which really encompasses all healthcare services, which include things like training, meetings, doing CME, as well as other clinical services as well. So the way I think of it is is that physicians are doing telemedicine in a telehealth environment.
Yeah, I agree. And then when we think about the telemedicine visit, I think what I'm hearing from a lot of physicians and really from practice managers in particular, is how they need to change the administrative workflow, right? So the clinical workflow is one thing, but what are some of those administrative tasks that they need to consider to think about as they begin to schedule, ensure that there's a right level of coverage, all of those elements?
Yeah, so as you can imagine, the workflow is definitely different in a remote environment. If a physician, let's say, is working at her or his home versus in a medical practice. In a medical practice, you have a whole team of support. You have somebody at the front desk, patient service reps, you have medical assistants, nurses, lab techs, and so on and so forth that support that visit. Whereas in a virtual environment, you don't have that staff in your area. So some of the things that definitely change is you have to work collaboratively with your staff at your office. So your patient service reps or your front desk staff have an added responsibility here where they are making sure that the patients are understanding the telemedicine visit and the details around that, making sure they have the right technology and so on and so forth, and sort of preparing that patient for the physician. And then secondly, the medical assistants can also support the visit by doing some screenings of the chart or the patient to, again, prepare that, do that pre-planning piece for the physician. And then working collaboratively together, the entire care team can then make sure that all of those components are in place so that physician does see the patient on time with all the information already that's required, that's in place. Like, for example, obtaining that informed consent, making sure the patient knows what the cost sharing requirements may be.
Yeah, it's all the requirements really that are important to ensure that the visit flows, right? So that, the patient knows what their responsibility really is related to the visit. And then also too, just making sure you have clarity built around how you bill it and the reimbursement expectations, both from the payer and from the patient.
Right. Right. And things are changing each and every day. When we look at the relaxed or the broadened waivers that came out on March 6th, we've had several changes already, not only with CMS, with many other commercial payers. They're changing the cost sharing requirements. They're changing the coding. They're changing whether a phone visit versus a video conference is required. So those are constantly changing.
One of the questions that came out from our webinar that you and Dr. Maisel ran for us sometime at the end of March was one around how the telehealth visit should be constructed, or can it be performed for a new visit versus an established visit. And clearly it's very advantageous for a follow-up visit for a patient that's already within a practice. But what about for a new visit? How is that structured? And maybe can you elaborate a little bit on that for our audience?
Sure. And so, Dan, with the March 30th release from CMS, they did expand coverage. And so now physicians are able to see new patients via telehealth and be covered. So for the most part, that visit is treated the same as it would in the office, and all the documentation requirements and medical necessity would apply as such. However, there is a level of risk, and many patients will definitely question whether or not they should be seeing a new patient because there is some risk there. So I would recommend that all providers check with their med mal carriers just to make sure that they have the appropriate coverage in place.
Yeah, I would agree with you. And, it's clear that an established visit just really lends itself well to the whole continuity of care of a patient within that practice. I think there's a real opportunity for them to include new patients in that, especially for those who may not necessarily have a doctor or maybe moved into that community. But I agree that's a great suggestion to check with their malpractice carrier just to see how it fits. And then to ensure that there's a comfort level built in with the physician and the clinical staff so that they have all the elements in place so they can see that new patient. Talk a little bit, if you can, about maybe some of the codes, at a high level. There's a lot of codes that are out there. Are there particular codes or particular, let's say, billing processes that you would recommend that the audience pay particular attention to as they think about how their coding needs to support the documentation, and of course the documentation supporting the clinical work?
Okay, Dan, so the way I look at the coding, I would probably sort it into 4 separate areas of services. The first one being virtual check-ins. So telehealth services allow providers to do patient-initiated, just brief check-ins on the telephone or using a patient portal or a smartphone for that matter, using video conferencing. And that is a really quick call. And what's great is in the past, these calls were not reimbursed. So providers talked to patient over the phone and they were not reimbursed for that time. That was included part of the E&M visit. So that is a service, a virtual check-in is a new set of codes that the providers can be reimbursed for. The second set of codes is around online digital evaluation and management codes, or e-visits. And these e-visit codes are using the patient portal. So for example, you have Epic and using MyChart. And if the patient and the provider are messaging back and forth, those could be billed out as such. And those codes are there's several codes depending on who the providers are, but for the most part, physicians and nurse practitioners can use the 99421 to 99423 for that set of codes. The third set is telephone E&M services. So this is using a landline where a patient and the physician are on the phone without any video and just speaking over the phone, and an E&M service is provided. So there's some medical decision making here. This is very typical of what happens in the office. In the past, Medicare did not cover this. As of March 30th, they expanded coverage on this. So the AMA was urging CMS to begin covering these services. And as of March 30th, these services are in fact covered. So I think many providers are going to be using these telephone E&M services, especially when patients don't have access to video or a camera and just have access to a phone. And then the last set of codes are around telehealth services using either audio or visual synchronous communication between the patient and the clinician. And these are your typical office visits that the physicians are currently using, 99201 to 99215. And to Dan's point earlier, we talked about using time to drive the level of the visit. I think many of those visits, time will be definitely the factor to determine the level of service.
So when we think through then the administrative workflow that has to occur to support the telemedicine visit, there's the pre-visit workflow, and I think the important component there is what the patient service representatives need to do to interact with the patients. I thought Dr. Maisel did a real nice job of talking about, the pre-visit activities and how you engage with the patient. And then of course there's the activity that needs to occur during the visit. And then you have the post-visit activities, as you had mentioned, the most common codes, and then understanding, how that needs to be reimbursed and so forth. Let's spend a few minutes talking about the level of reimbursement and how we, how practices can help think about the right codes and the structures and so forth. When Medicare went ahead and relaxed a lot of their requirements and allowed for the telehealth visit, they made it pretty clear in terms of what they were going to reimburse and the type of codes and so forth. There seems to be a lot of confusion out there from the commercial carriers. As you know, many of the commercial carriers have their own requirements. Some of them will allow certain modifiers to certain place of services, others don't. What advice would you give to our audience to help them kind of think through, that mess, if you will, and how to really understand what would be reimbursed and what are the requirements from their payers?
That's a good point, Dan. There's a lot of changes that are still occurring today, and I'm assuming they will continue to change as the weeks and the months go on. However, I think what this situation does is it provides us an opportunity to adopt telehealth technology and increase telemedicine services all across the board.
So, Lucy, I would think that as the practices become more proficient in telehealth, telemedicine visits, the revenue looks pretty consistent to an in-person office visit. But I can't help but think that the office expenses would be much lower. There's, if you think about it, the main expense that you have is going to be with the technology. There's not a whole lot of staffing expense there. I would think that the economics would prove out being pretty advantageous to a practice as they think about incorporating, let's say, 2 or 3 or even 4 visits an hour if they're able to get to that point.
Yeah, you're absolutely right, Dan. I don't think the margins are going to be that dramatically greater. However, I don't think they're going to drop. So if you think about it, to your point, the expenses will maybe a little bit less. You may need less staff. Plus, you're not paying the overhead expenses, if you think about it, of a building or whatever the case may be. So the margins will remain where they are or potentially even be better.
Are there any other advice that you would give to the practices that would help them kind of think about what they need to put in place or what they need to focus on in order to ensure that the telehealth visit, performs smoothly and actually is integrated well into their workflows?
I would think one of the most important things is to have a plan in place with a team and maybe a champion. So identifying somebody in your office who's very tech savvy, who can wrap their arms around the whole scheduling piece, the technology piece, and help train the providers and the other staff on that. I think that's important. And then tightening up that schedule, tightening up the workflow as well as that schedule, because you can't really be late on an office visit or virtually if you think about it.
Yeah, Dr. Maisel definitely highlighted that, and I couldn't agree with you more. I think making sure that those activities are really tight and you have good communication and set the expectation with the patients, I think are really going to be important. So Lucy, when talking to some of the practices, it's a little unclear in terms of what the requirements are from some of the commercial carriers. When Medicare released their new requirements or relaxed a lot of the requirements around telehealth and made it payable, they were really clear in terms of how to bill, what codes to use, the place of service, what the level of reimbursement is, and so forth. For the commercial carriers, there's been less clarity around that. Any advice that you would give to the practices on how they could, let's say, interact with the commercial carriers and provide a little more clarity around their telehealth visits and some of the requirements around it?
Sure. So the commercial carriers are definitely following suit. Many of them are having webinars and publishing their policies online. So I would recommend you practices should identify their top payers and obtain that information and put that together in a grid that identifies those policies, what the requirements are, what the patient cost sharing is, what codes they would want used, and the reimbursement as well. So I think it's critical that they do that now and then position themselves to continue doing telehealth services in the future. Dan, if you think about it, I think this is a great jumping off point to increase adoption of telehealth services.
Yeah, I couldn't agree with you more. We've been talking about this in the industry for quite some time. And now I think as practices start to expand their telemedicine, telehealth services to patients, this is really going to expand the access points for patients and allow us to really treat patients in a different manner that you can't help think is going to be really advantageous to the entire system.
Absolutely. And in the past, a lot of these commercial carriers even restricted or have exclusive contracts with certain vendors of telehealth services. So I think we're going to see an expansion of that primary care physicians and many of the in-network providers can provide telehealth services to their patients. And I think if you think about it, Dan, that also increases patient satisfaction and provider satisfaction as well.
Well, Lucy, this was great. Really appreciate your time today. I think you gave us quite a bit of fantastic information as we think about how we need to incorporate a lot of these administrative criteria into the telehealth visit. And I think it's a fantastic complement to what Dr. Maisel provided with us on our last podcast. So Shaillee, one of the things that I particularly enjoyed about our conversation with Lucy today was that she provided a real practical approach as to how the administrative criteria and workflow needs to complement the clinical workflow.
Absolutely. And what I like is, a couple of points that jumped out to me was take time to almost map out the workflow. Switching to telehealth technology, as important as it is to set up the actual technology part and train the providers, it is equally important to train the entire staff that is going to touch the workflow from beginning to end. So whether that's the pre-visit stuff, Lucy's suggestion on perhaps the MAs reaching out to the patient and prepping them for the telehealth visit, provider conducting the telehealth visit, and then the administrative staff knowing the appropriate codes to bill for so that the reimbursement is smooth. And I particularly like the idea Lucy shared, which was to maybe invest a little bit time looking at your top payers, researching and coming back with the grid. That could be such a helpful tool to smoothen this transition go forward, because these are not one-time changes. This continues to evolve. So really investing some time in that would be very valuable.
Yes, absolutely. And especially like you said, just, working with your commercial carriers to really identify what the billing requirements are, the level of reimbursement and so forth. I know for a lot of our clients, we've been helping them pull together this playbook that kind of outlines what needs to occur during a telehealth visit, the documentation requirements, coding requirements, billing opportunities, as well as the reimbursement opportunities. I would really encourage practices to almost develop a playbook like that on their own. It becomes a fantastic resource for the staff and the providers, for that matter, to really understand what needs to occur and how it needs to occur within the practice.
Absolutely. Well, Dan, I want to thank out our listeners for listening into today's episode of Value-Based Insights podcast. We at Lumina are your partners on the journey to value-based care. This topic is certainly top of everybody's mind. And to learn more about this topic, you can visit us on our website, www.luminahp.com. Don't forget to check out our insights page, where we have additional blogs, thought leadership, and even transcript from our podcast episodes. Join us again next time, where we continue to highlight topics that are top of your mind in these times of change. And until then, have a great day.